Surgical management of type 1 choledochal cyst. Type 1 choledochal cyst is the most common type, characterized by fusiform or cystic dilation of the extrahepatic bile duct. Surgical management is essential to alleviate symptoms, prevent complications like cholangitis, biliary stones, or malignancy, and restore normal biliary drainage. Below are the detailed steps and considerations in its surgical treatment. Hadasher, preoperative evaluation. 1. Imaging studies. Ultrasound, USG, initial imaging to identify cystic dilatation of the bile duct. Magnetic resonance cholangiopancreatography, MRCP, provides detailed anatomical delineation of the cyst, biliary tree, and pancreatic duct. Endoscopic retrograde cholangiopancreatography, ERCP, used selectively for therapeutic purposes or to evaluate pancreatico-biliary maljunction. 2. Laboratory tests. Liver function tests to assess bile flow obstruction, coagulation profile to ensure surgical readiness. 3. Preoperative optimization. Treat infections if present, e.g., cholangitis, with antibiotics. Manage nutritional status and correct electrolyte imbalances. Surgical procedure. The standard treatment for type 1 choledochal cyst is complete cyst excision with biliary reconstruction. This prevents complications such as recurrent cholangitis, stone formation, or malignancy. 1. Complete cyst excision. Objective: remove the entire dilated extrahepatic bile duct, including the cystic component. Steps: laparotomy or laparoscopy is performed to access the biliary tree. The cyst is carefully dissected to avoid injury to adjacent structures such as the portal vein and hepatic artery. The proximal bile duct is transected at the junction with the intrahepatic bile ducts. The distal bile duct is dissected down to the pancreatic duct opening and transected. Care is taken to avoid leaving any remnant cyst wall to prevent recurrence or malignancy. 2. Biliary reconstruction. Roux-en-Y hepatocogenostomy. A Roux-en-Y jejunal loop is created. The proximal end of the jejunum is anastomosed to the hepatic duct to establish bile drainage. This is the most common and effective reconstruction method. Alternatives like hepaticoduodenostomy may be used in specific scenarios, but are less common due to higher risk of complications like reflux cholangitis. Postoperative care. 1. Monitoring. Vital signs, signs of infection, and bile output if a drain is placed are closely monitored. Liver function tests are repeated to ensure normal bile drainage. 2. Pain management. Adequate pain control with analgesics. 3. Nutrition. Gradual reintroduction of oral feeds. Parenteral nutrition may be required temporarily if the patient is unable to tolerate oral intake. 4. Complications. Early complications. Bile leak, hemorrhage, infection. Late complications, anastomotic stricture or recurrent cholangitis. Long-term follow-up. 1. Periodic monitoring. Regular clinical evaluation and imaging to detect complications like anastomotic strictures or stone formation. 2. Malignancy surveillance. Though rare after complete excision, lifelong surveillance may be necessary for those with incomplete cyst removal or atypical cysts. Minimally invasive surgery. Laparoscopic or robotic approaches are increasingly used for cyst excision and reconstruction. These offer advantages like reduced postoperative pain, shorter hospital stays, and faster recovery. However, these require expertise due to the complexity of the dissection and reconstruction. Prognosis. With timely and complete surgical management, the prognosis of type 1 choledochal cysts is excellent. Most patients experience significant symptom relief and a marked reduction in the risk of complications, including malignancy.